Welcome to another episode of the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today's episode will be a question-answer session. I have a couple of good questions that you guys have submitted, and I'll try to answer them to the best of my ability. The first question today is going to be about colostomies. The second question will be about acupuncture treatments. The third question will be a poop question. We love poop questions here. And the fourth one will be more of a how did you decide to be a gastroenterologist question. That's more of a personal question, but maybe I can make that interesting too. So here we go. The first question is from Laura Jean. And the question is, do people with a colostomy still get colonoscopies? How is it done? So it's a good question. People with colostomies, which is basically a bag that you have to use to move your bowels in, after having surgery or some other procedure where you had to have a part of your bowel resected, either from cancer or because you had a diverticulitis episode and you had a perforated bowel, and there's many other reasons why people end up getting colostomies. But what a colostomy is, it's a bag that you attach to your skin, and it's attached at a stoma, which is an opening from your intestine to the skin that's surgically created, and your poop basically goes into that bag. And when it's full, you have to empty it. And I don't think anybody enjoys having an ostomy, but it's a part of life. And many patients have ostomies who have had previous colon cancer, bowel resections, inflammatory bowel disease that's required surgery, and many other conditions. So yes, the answer is you can still have a colonoscopy if you have an ostomy. It's commonly done, and it's simple. It's just the same way as you do a regular colonoscopy, but instead of inserting the scope in the patient's anus, you insert it into the ostomy stoma. So you take the ostomy bag off, and you use the scope right through the ostomy. The difference is that the patient, instead of facing away from you, is facing you. When you're in the endoscopist, they're laying on their side, but their face is towards you as opposed to being away from you, which is the way a typical colonoscopy is done, which makes sense because their butt is on their backside of their body, not where their face is. So that's why we do it that way. But yes, you can do a colonoscopy on someone with a colostomy. It's the same, all the same techniques. Everything is done exactly the same way. I tend to use pediatric colonoscopes for everybody, so I would say use a pediatric scope because of the ostomy. Sometimes the ostomy stoma is small, and an adult-sized scope would be a tight fit. And in theory, you could damage the ostomy stoma if it's either not mature enough or if the surgery wasn't done long enough ago, but also just with enough force, you could potentially damage it. So that's not something that I've ever encountered, but in theory, it could happen. I would advise using a smaller scope and being gentle, but yes, it's done, and it's done frequently. The second question comes from Patrick, and Patrick asks, what do you think of acupuncture? So that's a good question, but it's kind of broad, so I'm going to have to try to narrow this down a little bit. So acupuncture in general, I don't really have any thoughts on because I don't know enough about it to make an intelligent comment. But people do use it for various different GI maladies, and patients come in all the time saying that they used acupuncture to treat various different things. And sometimes it's not bad, and sometimes it's maybe a little misguided depending on what the condition is. So I would say for conditions like irritable bowel and dyspepsia and like abdominal pain that we don't have the answer for, it's not a bad idea to try stuff like that if you think it's going to help you, because there are some studies that show benefit in acupuncture for various different gastrointestinal problems. And these studies have been done with patients who have functional gastrointestinal problems, meaning that they've hopefully undergone an investigation and they have irritable bowel or some other poorly understood functional illness that's causing them a great deal of grief, and they've tried standard medical therapy and nothing has really helped. And these are frustrating conditions for us gastroenterologists to face because we don't really have a cure for irritable bowel syndrome. There's a lot of things we can do for it, but there's no universal best treatment. And if these complementary or alternative methods are useful, then that's great. I'm all for it. So what do the studies show? if you look up, I didn't spend 8 hours researching this, but I did look at a few meta-analyses showing a benefit of acupuncture in certain gastrointestinal conditions like functional dyspepsia, irritable bowel syndrome, functional constipation, and there was a slight but significant increase in patient positive outcomes, meaning less pain, better bowel movements, in the patients that used acupuncture. However, they say even in the meta-analysis that I looked at, just looking at all different studies that were performed with acupuncture, the level of evidence is moderate to low quality. So these are hard things to study. I mean, it's hard to give someone acupuncture in a placebo-controlled way. You're bringing them into a treatment area, you're sticking needles in the skin. It's hard to fake that, although it did mention in some of these studies that they do have a placebo acupuncture needle that doesn't penetrate the skin, or it only penetrates the skin a tiny little bit. And, potentially that can improve the ability to study this modality, but it's still very hard to study in a double-blinded fashion, meaning that the researcher and the patient doesn't understand if they're getting acupuncture or not getting acupuncture. That's the best way to study it. So nobody really knows what was given, and then they just look at the pure data. It's hard to do that. And plus, the intervention itself of acupuncture, it involves some degree of standardization in the process where it's done. You're probably doing it in a quiet room. You're the patient, or the study subject, or whatever you want to call it, the person is devoting time and getting attention in this manner. And some of those things may actually trigger a placebo type response where the acupuncture seems to work, but in fact, it's really just the whole situation where they're focusing on their health and they're in a quiet place and they're not doing anything else at the time. And maybe it's just the mindfulness and the meditation component of being in a quiet room and focusing only on your issues that may promote some type of benefit. Who knows? It's very hard to tease these things out from studies that are done, especially a meta-analysis type study where they're looking at multiple other little studies that were not really all designed the same way. But it doesn't seem like it's particularly high risk, although there are some people do get injured from acupuncture. It seems to be pretty low risk in terms of all the interventions that we have out there. So if there's some data for it and it's been used for a long, long time with no major severe safety signals and nothing else is helping, then go for it and you see what happens. I think the proof is really in what happens. So if a patient tries it and it works, meaning they got better, then how can I say that that's not a good idea, even if there's not a ton of data for it and it doesn't seem, as long as it's not inherently dangerous. There was also another study. This is kind of cool. This is like bringing acupuncture up to the current times. They did a study with functional MRI, so they can do like an MRI scan in real time, and they see what's happening to the different parts of your brain, which parts are being activated, and which parts are consuming lots of resources, and they can see which parts of your brain are being activated. And they did some functional MRI scans. Actually, this is another meta-analysis looking at 10 different trials using functional MRI in functional dyspepsia, irritable bowel syndrome, and constipation. And they found that there's different areas of the brain that get activated when you have acupuncture. And that's pretty decent proof that something is doing something. So whether or not it's the actual needle entering the skin, or it's the belief that that's going to help you, or it's the whole atmosphere, or whatever it is, it's pretty interesting to see like actual functional MRI data that says that something happens when you do acupuncture. So, and patients reported decreased abdominal pain, distension, and better frequency of bowel movements and better stool characteristics, and also some relief of anxiety and depression symptoms with acupuncture. So again, it's like anything else in the complementary world. As long as there's a reasonable chance that it's not going to cause harm and you're not doing some like crazy thing, like ingesting some type of toxin or doing something like that, and there is a possibility that may help you, then you give it a try. If nothing else is working, you give it a try, you see what happens. You keep an open mind, but at the same time, be skeptical. And if you're wasting money on something and there's no real benefit, you haven't felt anything, you feel the same, then maybe you give it a couple of weeks and you stop it. But if you're feeling better from it and it's the actual treatment, or if it's the quote placebo effect, then really at the end of the day, who cares? Because if you're feeling better, you're doing something and you're feeling better from it, then that's really all that matters, because the placebo effect is real. So either it's the placebo effect or it's the actual needle entering the skin and whatever that does. I can't argue with success. So if it's working for you successfully, then go for it, and just keep an open mind, but also be skeptical about all the stuff that's out there that gets classified as hokum. So that also, this is a long-winded answer to a simple question, but I think it's also important to understand the role of a gastroenterologist or a medical doctor in the treatment, the diagnosis and treatment of a lot of different conditions. So sometimes we don't have answers, and our job is to rule out some of the things that are harmful. So lots of people come in with belly pain and issues like constipation and other gastro-related conditions, and a lot of those things are not severe illnesses that are going to hurt or kill the person or cause cancer and whatnot. So part of our job is to differentiate the people who have some severe illness that's going to cause great harm to them and cause morbidity and potentially cause mortality, and differentiate that from the conditions that are very distressing and annoying and reduce their quality of life, but are not going to harm them in any physical way. So we have limited understanding of what causes irritable bowel syndrome and some of these other functional diseases. And the understanding seems to be improving over the years, but we're still not there yet where we know exactly what causes this in every person. And there's lots of different causes in lots of different people. So part of what we do is we do some testing and we do some diagnostics to figure out what we're dealing with. And if we don't find anything that is immediately life-threatening or chronically going to cause a problem in someone, then I am all for doing whatever it takes to make that symptom go away. But the caveat to that is that I've had plenty of patients come in with diseases that we do have management for and that we do understand a lot about. For example, Crohn's disease, ulcerative colitis, ulcers, gastrointestinal cancers, who come in with a diagnosis, or we make a diagnosis here and there's good treatments out there, but they don't want to do them because they're not, quote, natural, and they'd rather try a lot of these alternative medicine things instead. And when you're dealing with something that could potentially hurt you, kill you, harm you in some way, I think you have to respect modern medicine as well and understand what the standard of care is, and why that standard exists for a reason is because that's probably the best way to help people through these conditions. And I've seen plenty of people who they come in, they get a diagnosis, they reject all the treatments, and they do some type of alternative medicine, and it doesn't get them anywhere. Besides they lose 6 months of time where we could have maybe caught up with some potentially devastating illness, like a cancer. So that's always a tragedy when I see that kind of thing. So I would say you keep an open mind with alternative medicine, and you do things that don't seem harmful and try them if you have a disease that we can't kind of fix the normal way, or that you can't fix with diet, lifestyle, and all those simple things. So that's enough about that. Interesting question, opens up a whole can of worms, and maybe we'll address something like this in the future again. And now, on to a lighter subject, or maybe a darker subject. This question comes from Kathleen, and Kathleen asks, why is poop brown? So that's a good question. The color of poop. Is this something that's silly? Not at all. It's something that we address here all the time as gastroenterologists. And if someone's poop is light or dark or red or whatever, it's a constant thing that we talk about in the world of GI. Is this really what I wanted to do with my life? Talk about people's poops? It's not really, but it's very important. It comes up all the time. People show me pictures of their poops on their cell phones all the time, which, well, by the way, is why I usually don't want to touch anyone else's cell phone, just so you know. But people show me pictures of their poops all the time on their phones. They want to know what this color means. Why is it this color? Why is it that color? Why is it green? Why is it dark? Why is it black? There's a million different shades of poop colors, and we learn how to interpret a lot of this stuff in the world of GI. So the simplest question is, why is my poop brown? That's like the default color that it should be. And the reason for that brown color in the poop actually comes from a complicated metabolism of something called bilirubin. So bilirubin is something that many people have heard of. It's formed by the breakdown of heme, and heme is a pigment found in hemoglobin, which is part of your red blood cells. It's the oxygen-carrying component, or the oxygen-carrying pigment in your blood that allows us to live. Your blood is red because of hemoglobin, and heme is the thing that's holding it's the iron moiety, as they call it, or whatever you want to call it. It's the iron cage that's holding the oxygen. And heme is found in hemoglobin, myoglobin, and some other enzymes in your body, like cytochromes and other things. And that is not a it's not immortal. It breaks down like everything else in your body, and it has to get either excreted or recycled or recirculated. And what happens in your body is that hemoglobin, after it's run its course and you've used your blood cells for many, many, many trips around the body through the heart and everywhere else, the diseased or the dysfunctional or the red blood cells that are starting to deteriorate, they get picked up by your body in various different places, mainly in the spleen, and they break down. And the body is smart and it wants to recycle heme, and it breaks down hemoglobin and eventually forms a substance called bilirubin, which has a dark green, brown, yellowish pigment to it. And bilirubin is metabolized further by the liver and eventually is excreted by the liver into the bile ducts, and the bile ducts eventually drain into the intestine. And bilirubin makes up bile, and bile helps you digest your fats in your food. It acts like a soap. Bilirubin will help to break down fat particles into very, very tiny little particles that are more easily digested. As it's traveling through your intestine, some of that bilirubin gets absorbed and recycled back in the liver to save the bilirubin so you don't have to keep manufacturing it. But a small fraction of it does make its way down to the colon and gets excreted and turns the stool a dark color. Bacteria in the colon act on bilirubin and they form these brown pigments. So when everything's working properly, your body's breaking down hemoglobin that's been used up and old. It's producing bilirubin. Bilirubin is being excreted by the liver. It's entering the gastrointestinal tract through the bile duct. The bile duct happens to run through the pancreas on the way to the intestine. When you eat a fatty meal, your gallbladder squeezes. It excretes some of the stored bile. Your bile duct is pushing bile down the duct, and you end up with bile in your intestinal tract. Some of that makes its way down to the colon. A lot of it gets reabsorbed and recycled, but the fraction of it does make its way down to the colon, and it gives everything that dark, brownish, greenish color, which is the normal color of stool. So it's important to know this, not because it's great trivia at a party, but when you're a doctor, you have seen the patient who comes in jaundiced, and you've seen a patient who comes, which means their skin turns yellow, and you've seen patients who come in complaining of pale or white colored stools or clay colored stools, some people will describe it as. And what that is it's a blockage somewhere in the system. Typically, it's somewhere in the bile duct where there's a blockage and your body cannot excrete bile because the normal pathway of bile from the liver down to the intestine through the bile duct was mechanically blocked by something. And now the gut doesn't have bile flowing in it anymore, and there's a lack of that normal pigment to the stool. So your stool is more of like a off-white color, which is usually distressing to people for a good reason. So they come in, we check their lab work, we check their bilirubin levels in their blood, because if the bilirubin cannot get excreted into bile, oftentimes it builds up in the blood and goes up to the point where they become jaundiced or their skin turns yellow. And we see in the blood work that the bilirubin level goes up, or you see other signs in the blood work that something's wrong. And also the stool turns that white or pale color. And we'll do some imaging and we'll often find a blockage somewhere in the bile duct. Either there's a tumor in the pancreas causing a blockage, or a tumor somewhere else in that area, or a stricture, or a gallstone that got jammed into the bile duct and caused a blockage. And there's many other things that can do this, but those are the common ones. So if your stool is brown, that's normal. This is normal part of human circulation of bile into the gut in the breakdown of hemoglobin. And if your stool is not that color, it's not always something bad, but you do have to look out for certain significant diseases. What about when the stool is a light brown or a dark green or a black color? These are all different situations, and those really should just be addressed by your doctor. If you're having weird colored stool, you should probably see somebody to talk about it. And the last question, which probably ties into the poop talk a little bit, comes from Nicole. And Nicole asks, how did you decide on this area of medicine? Now, not surprisingly, I get asked this question all the time. And I often ask myself this question: how did you decide on gastroenterology? When I was in high school, I didn't even know what a gastroenterologist was, let alone want to be one. And I think if I told my friends in high school that I wanted to be a doctor that specialized in the GI tract and had to deal with lots of things, but often poop and stool and blood and all these interesting topics, they would have probably laughed at me and called me a strange, individual. So, or, whatever they would have called me. I probably can't say on this show. But I think I've been interested in medicine for a long time. I don't know where that came from. It's just a thing. As a kid, I was interested in the body. I was interested in medicine. I was reading textbooks on medicine that we had at home, or just not really textbooks, but medical books like the household, medical encyclopedia. It was just something that fascinated me. I really liked science. I liked trying to figure things out. I would be doing little experiments with whatever concoctions I can find and household, chemicals and baking soda and just whatever. I always had this part of me. So I figured I had to channel it into something that was useful, and medicine seemed like the obvious thing to do. When I went to high school, I originally thought, I actually injured myself. I injured my hand. I cut my hand on glass, and I got to see some tendons moving around in there that kind of was not normal. It was kind of scary, but it made me very interested in all this anatomy stuff. And after having surgery and getting things fixed, I remember walking around Barnes and Noble, which I guess there's still some Barnes and Nobles around, but not that many of them. But there used to be a Barnes and Noble in my town, and I found a anatomy textbook called Netter's Anatomy, which is still like a good anatomy textbook. And it had all these intricate details of the hand. I was looking at these tendons and these like pulley systems in your hands and the ligaments, and I just thought it was the coolest thing. And I eventually figured that I probably wanted to be an orthopedic surgeon. That sounded like a really cool thing to do. You get to put people back together and fix broken things and work with power tools and do all that fun stuff. So I got into med school and did the orthopedics rotations in my third year, and quickly found that it was boring to me. It was a cool field and they do good work, but to me it just seemed like, I don't know, they were just hammering knees together and doing whatever, and it just did not hold I think I zoned out during the operations while I was holding a retractor many times. So it did not seem to have that interest once I actually got there and saw what it was like, and that's why you go to med school and you do all these different rotations. So I figured once I was actually in school, all this physiology and medical type stuff really seemed to be more interesting to me than just the mechanics of it all. And I realized that people are having heart disease left and right. You see so much heart disease in medical training that it seems to be like the most important thing to focus on. So I figured I should be a cardiologist. And I think when I got married, I told the priest that I wanted to be a cardiologist, and he made some announcement to the church that, a future cardiologist here, this and that. Well, that didn't turn out to be the case, but, the marriage did, so that was all that matters. But the cardiology thing, I did rotations in cardiology. I found it very interesting, but it was a little too, I don't want to say serious, because medicine's serious in general, but it was a little too acute and maybe fast-paced for what I liked to do. And I decided that was not the fit either. I don't know why. It was just a feeling I had. So the next rotation that I did in med school was general surgery. And I did this rotation at one of the VA hospitals. And I loved it. I thought general surgery was awesome. You were doing all this cool work. You were doing life and death stuff. There were a lot of good personalities. It was fun. I actually enjoyed it quite a bit. The teaching attendings that I had at the time were great, and because it was a VA, it was a little laid back. You could actually read and learn stuff and weren't just running and doing work constantly, patient care type work. In medical school, you were actually learning, which is what the point was. So I loved my general surgery rotation there, and I also realized that I did not want to be a general surgeon. Like any other field, the time where you're actually operating and doing what you're trained to do and love to do is minimal, and the time where you're doing all the other stuff seemed to be most of the day. And of course, that's the perspective of like a medical student / medical intern. And I'm sure as you grow up, you'll do a lot more surgery and do a lot less nonsensical stuff. But at the time, I said, this is also not for me. It was cool, but I didn't see that it was a sustainable life. And what happened was I was on my general surgery rotation, and there's a lot of interplay or interaction between gastroenterology and general surgery. There's a lot of tumors and things that are diagnosed, and a lot of hepatobiliary illnesses that are diagnosed and handled by a joint effort between gastroenterologists and surgeons. So we have we would have weekly conferences, tumor board conferences, and we just would interact with each other on the same patients repeatedly. So I got to work a little bit with the GI people, and just as a med student, I got to see a lot of that go down. And I thought that GI was kind of cool. You can come in, make some recommendations, do a quick test like a colonoscopy, fix some bleeding, and it just seemed like a neat thing. But I was very concerned because we did some colonoscopies on the general surgery rotation, and I had this feeling about colonoscopies that they were like impossible, because a general surgeon can take out a gallbladder in 20 minutes or whatever it is and make it look like it's easy. But to watch a general surgeon do a colonoscopy is anything but that situation, or at least where I was at the time. And this is not to like badmouth surgeons doing colonoscopies. It's just a matter of training. I think, if they do a colonoscopy every week or two at a VA type hospital and they do, surgery much more frequently, it's just like a different, they're just not doing as many. They just don't have the techniques down. Just as if I tried to take out someone's gallbladder, it would not go very well at all. Plus, I'm not trained in that as a medical doctor, gastroenterologist. But it's one of those things that if someone does something 1,000 times, they get really good at it. And if someone does something once in a while, it's a struggle. And there was a day where I was in the endoscopy suite with on my general surgery rotation, and the surgeon was trying to train one of the surgical residents on how to do a colonoscopy. And the scene, it was literally like a movie, like a cheesy like 80s submarine Cold War movie, where there's 3 guys in the room. Everyone's sweating. The lights are low. The patient is luckily under anesthesia, and the tensions are high. The resident is trying to get the scope from the patient's sigmoid colon up to the cecum or whatever the situation was, and it seemed like it was never going to happen. It was like high drama. There was twisting and turning of the scope, patients moaning, moving around because the sedation they gave back then was not so great. It was like moderate sedation. It wasn't really like propofol sedation, so it was kind of like Twilight. The attending was grabbing the scope and trying to instruct the resident, but didn't really have the vocabulary or whatever it was to actually instruct them properly, and it ended up being just kind of like a nightmare scene. I feel like my heart rate was 110, thinking that something horrible was going to happen. And this was repeated again and again with most of the patients who were getting these procedures. And eventually they got to the cecum and nothing bad happened, but it was like every case seemed to be like a Hail Mary, are we going to get there or not? And I thought of colonoscopy as this insane procedure that like just didn't seem right. But then one day I'm in the endoscopy area again because we got stuck there a lot. And I see this young guy come in who it turns out was a gastroenterology fellow at the university who was doing some rotations at the VA. I didn't know who he was, but he waltzed into the endoscopy suite wearing his shirt and his tie, looking completely cool, unflustered, like it was just another day in the office. And he walked in, he had his list of patients, he had his procedures, and I just saw, because the way that the rooms are set up, you can kind of like see into the other rooms from inside the endo suite. I just see him and one of the nurses just talking about whatever, doing the colonoscopy, getting to the end of the cecum. It looked like he was not doing anything. It looked like he was just kind of like driving the scope there, like as if he was playing golf. There was no sweating. It was not a high stress situation at all. So I kind of popped my head in and said, like, who is this guy? And they said, oh, he's the 3rd-year GI fellow, whatever it is. So he's been doing this now for a couple of years. And at the VA, there was little oversight at that time, and you're able to just go in and scope and do whatever you wanted as a GI fellow. And I said, wow, I totally had this wrong. I think colonoscopies are cool. It seems like they are not a complete fiasco when you're doing them all the time and you're trained for them as part of your day-to-day job. So after that, I did a GI rotation, and I kind of fell in love with it. I thought it was great. It was a good mix of clinical medicine, where you're talking to patients and trying to figure out what they have and making a diagnosis, and also a good mix of hands-on procedure type medicine, where you're doing procedures and colonoscopies, endoscopies, and all these relatively quick and usually not too painful type procedures. And you're finding stuff that's changing people's lives. You're finding colon polyps and removing them to prevent colon cancer. You're stopping bleeding. You're figuring out the source of all kinds of different symptoms by doing these tests like endoscopies and colonoscopies, they're relatively quick. You can do a bunch of them. The patients have a good experience for the most part. The doctors, once you're good at them, it's a pretty easy type of procedure to do. And there's still an art to it, and of course you can screw it up, but it's not anywhere near like what it was like when I saw those the Hunt for Red October going on in endoscopy room number 1. That was definitely a scene I'll never forget. But that's how I got into GI. And once I got into it, I realized it was actually the people in it were kind of cool. Most of the doctors who do GI have somewhat of a sense of humor. I think you have to in this field. And the crossover between a lot of the GI illnesses that we see with healthy lifestyle and healthy diet and exercise and all the things that I otherwise like to do and talk about was apparent. So it's a field where I can work with my hands, I can see patients and talk to them, and I can also promote some healthy living type stuff that I like to do anyway. So that's how I chose GI. And I guess at this point, there's no going back, even though I have to talk about poop more than I'd like to. All right, guys, I hope this Q&A session was fun. And if you have any questions for me, please submit them by finding me on social media at RealGIDoc, RealGIDoc, really anywhere, and send me a message there or leave a comment with a question. And the best way to do, if you don't find me there, the best way to leave a question is to go to realgidoc.com, and I'll leave a link below. And you can leave me a 90-second recorded clip with your voice, and you can leave a question for me that I'll play on the air and answer your question. Just leave your name, your first name, I don't need your last name, and whatever town you're in or whatever state you're in, so I can add some context to the show. So hopefully you enjoyed, and I will see you next time on the Real GI Doc Show. Thank you.
That's it for this episode of the Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.